Okay, so we're going to change gears a little bit and talk about the different studies that we have done to sort of look at is the spirometry pre and post deployment helpful? This idea came out of our original meeting at National Jewish back in 2010, and that was one of the questions that we were asking since we didn't have much data on that. So I'm going to show you the different ways that we have looked at it in our population. Once again, I work for the DoD. These are not my views. These are my views, not theirs. And I'm going to talk about 4 studies that we've done, or actually 5. So screening spirometry study in military personnel. We wanted to look at the baseline of what these folks looks like early on in their careers. We have data from Air Force firefighters. It's unpublished. We have data on asthmatics who actually had pre-deployment spirometry. And then we have 2 articles actually from STAMPEDE II, one looking at the baseline characteristics by Skabeland et al., and then this is the second one we published earlier this year in respiratory care that looks at the post-deployment values. So screening spirometry, the idea behind the study was to look at our baseline population within the DoD and see if we could come up with any particular ideas on how to approach these individuals. And you can see the numbers right there from this publication. So when we looked just at whether or not there was the presence of obstructive, restrictive, mixed, or flow volume loop abnormalities on spirometry, and this was a healthy group of individuals doing advanced individual training down at Fort Sam Houston. So they've been in the military for about 6 months. They are not supposed to have any underlying lung disease, which we find out they do. But when we look at just the number of abnormal studies, we got about 11%. So the original goal of the study was to evaluate many of these patients. It didn't happen. But when we went back and looked at the abnormal studies, and we looked specifically at gender, smoking, symptoms, history of asthma, prior coming to the military, or failing their PT test, we did not really see any differential between those symptoms. Did not correlate with the findings. The only thing it did correlate with when we did the logistic regression analysis was elevated BMI. So we found some abnormalities in that. Now, that being said, we did a single spirometry at a single setting, and we did not do any follow-up testing on these patients. Anyway, so if you look at the graph from the study, this shows our population. We had 900 folks, 802 that had normal studies, and you can see the distribution of the values to include smoking, APFT failure, symptoms of cough, symptoms of dyspnea, or prior history of asthma. And we didn't really see any correlation that any of those factors would lead you to find a higher rate of abnormal spirometry results in this population. So from the onset, we know that about 10% of our population are going to have some abnormal spirometry, and they're probably non-specific findings, and they don't necessarily indicate underlying disease. Okay. So the next group that we have, and we've looked at, was firefighters. So we have a group of Air Force firefighters who, by Air Force definition, are required to get periodic surveillance spirometry while they're in the military. So we were able to go back and take all the data that was in our electronic medical record. We looked it up and then looked at both 1-year data or single deployment data and then 5-year data looking longitudinally. So this is the initial data that we presented before of those with looking at a single PFT pre and post deployment, and noticing that we had very little change overall in the means of these patients. They actually were a little bit better in terms of actual values. We had 3 subjects that had both a decrease in their FVC and FEV1. We had 1 subject with a decrease in their ratio suggesting new onset obstruction, and then 2 subjects with a decrease in the midflow. Now, this was done retrospectively. We did not see these patients or evaluate patients. We were just taking their PFTs out of the charts and looking at that. So when we looked at, so we didn't see a signal there. When we looked at over 5-year data, so we'd have 100 patients in whom we have a 5-year gap between their initial spirometry and their second spirometry, or they have one between 5 years. Some of them have multiple PFTs as well. But they had deployed at least one time between their initial spirometry, which they do at their course down at Lackland Air Force Base, and then follow on. So we tried to find those individuals that had one or two. Actually, we have up to individuals with 3 deployments between the 0 point and the 5 year point. And once again, if you look at in the meantime between the Spiro is about 6 years. And once again, if you look at the initial data, overall it looks very much unchanged. There's a little bit of decrease in the FEV1 ratio to FVC, and there's a pretty much unchanged in the FEF25, which is a marker of small airways. When we looked at the changes specifically for individuals, we did not. You can see the ranges right there. Most people had a very mild change. A few patients fell outside the normals on either end of the spectrum, but it was very few in terms of that number. We've subsequently, and I don't have a slide for this, gone back and analyzed this data and showed that over the 5 year mark that the spirometry between deployments doesn't change all that much, but if you break it out between smokers and non-smokers, there's a significant difference in the spirometry for those that smoke versus those that don't smoke. So there seems to be some role of smoking in this population as well. We've also went back and looked at specifically those asthmatics that deployed. So as asthma, number one, doesn't necessarily get you kicked out of the military, and number two, does not prevent you from deploying. So we had a database with about 17,000 people in it that had a history of asthma. At least three encounters with an ICD-9 code for asthma, and we went back and looked to see if we could identify those patients that had a prior diagnosis, had deployed, and if their PFTs changed after that diagnosis. So we actually found 642 out of this cohort that we could find spirometry on. Okay, so our spirometry, like I mentioned earlier, is put on a PDF and uploaded into the electronic medical record, so it's hard to search it. So it was during this time period we had documented that they had a deployment to Southwest Asia between these times. And of the 642 that had spirometry, we could only identify 71 individuals that actually had a pre-deployment and post-deployment spirometry. So there is no regulation within DoD saying that you have to be evaluated before your deployment. And generally, the pre-deployment and post-deployment questionnaires are fairly vague in terms of the questions they ask in terms of symptoms. So that's why probably the small number of patients that actually had spirometry. So the mean interval between is about 3 years. And of that group, we found 35 that actually had pre- and post-bronchodilator testing. Okay, so when we look at the values on here, this is our demographics. So roughly, about 80% male, 20% female, which is pretty consistent with the overall deployment group. Deployments, they had an average of 1.7 deployments for this group of patients, and deployment length, when we measured that out, was about 200 days per deployment. Once again, when we looked at this data specifically, we found little difference in the basic parameters, FEV1, FVC, and the ratio between these two groups of patients between pre- and post-deployment. In looking at those that also had bronchodilator testing, the 35 individuals that had that, we also found no difference between the groups as well. So actually, there looks like there's a little bit of an increase, very, very small group, and you can't make anything out of those p-values. So there's a very limited number within our DoD system, within ALTA, that actually have pre- and post-deployment spirometry. Like I said, it's not a requirement. We did find that 83% had confirmatory testing to prove their diagnosis, but when we further went down, and I don't have slides on this, to look at ACT scores, ICS dosing, or LABA use, we could not find any differences between the individuals that we studied in this group. But once again, it's a very, very small group of patients with only 71 that we had PFTs on. So that leads me into STAMPEDE II, which is our big study that we developed to look at should we routinely get spirometry on the deploying population in order to detect or identify disease returning from deployment. So these were all deploying soldiers out of Fort Hood, Texas. They were about a third Guard, about a third Reserve, and a third active duty. That all deployed out of there. We actually had a PFT tech, and we put a spirometer at the Soldier Readiness Processing Site. They all have to go through there on their way out the door, and they all have to come back through there on the way back. We did spirometry, impulse oscillometry, and a respiratory questionnaire to ask about the symptoms, and we were able to enroll about 1,700 soldiers during a 3-year time frame. 83% male. You can see the age, so they're a little bit older. They're not 20-year-olds. They're about average age is 32, and the never smokers was only 64%. So when we looked at the pre-deployment data, this is pre-deployment only. Those who of the 1,700, those that had a prior deployment, prior to the one that we tested them on, you can see the values up there for all the spirometry, and there was no significant difference in those patients. We did show that in this group, and we did ask about asthma history, that we had about 11% that actually were obstructed at baseline prior to deployment. And in looking back through their charts and trying to identify if they had been diagnosed with asthma or not, we couldn't find any confirmation of it in the majority of these patients. We did not, at the onset, we did not differentiate any medical history at all. We just took deployers as they came through the SRP site. And you can see the values that I just showed you right there. So this is pre-deployment as well. When we looked at it, trying to look, was there a correlation between abnormal PFTs and other symptoms? So when we asked smoking history, there seemed to be a little bit higher history of smoking. There was more frequent symptoms that we identified in terms of respiratory symptoms in the prior deployment group, and a little bit more with comorbid conditions, reflecting the fact they may have been a little bit older. And you can see clearly there was a higher history of PTSD in this group because of prior deployments. When we looked at it and tried to compare it specifically to whether or not normal or abnormal PFTs, we did see a trend that the smokers had higher level of abnormal PFTs. Those that had given us a history of asthma on the questionnaire had a higher history of PFTs, and then any symptoms as well, a little bit higher difference in those patients, but no difference in comorbidities between normal and abnormal PFTs. So from our original paper that we put out, we noticed that nearly 1/3 of our surveyed soldiers had a smoking history, and there's good data to suggest that with smokers there's actually a higher rate of smoking while in theater. 73% met the definition of being obese or overweight. So these are not young, healthy, thin folks. I showed you the age, they're a little bit older. Population, 6.2% reported a history of asthma. We could not find documentation in the chart they were actually being treated for it. And then we found that there was abnormal spirometry in about 22% of our participants, and it correlated more with asthma, failed physical fitness test, and active respiratory symptoms. And this is all in the pre-deployment group, so before we looked at them coming back. So these are when they returned, we got about 700 individuals that came back and went back through the SRP site. We missed a number of them. Some of them, because they're not stationed at Fort Hood, got sent directly home. Some of them were hard to get home, and even though we had the person there, so it was about 50% that redid the study. So we asked them specific questions on the way back. Did you have symptoms before you went? And you can see as the general trend is that they increased while they were deployed, and that's a very common finding, and went back to baseline levels when they came back from their deployment. So when we actually looked at the mean values for the post-deployment PFTs, we were not able to see a difference. FEV1 didn't change, FEC didn't change, FEV1 ratio or did not change. And when we looked at the iOS values, R5, R20, and X5, they all got better, and there was a significant difference, but it went in the direction of improvement. As the R5 and R20 drop, that shows more normal lung function, and as the X5 drops, that also shows more normal lung function. So the only significant finding was, at least from an iOS standpoint, which we don't use a lot clinically, there was an improvement in their lung function. So when we looked at specifically, we went back and looked at the group and we asked questions about symptoms to see was there a difference in the patients that had symptoms, and we divided them out, those that were normal and those were obstructed. Of the overall group, we found about 90 people that were obstructed. 30 of them improved and became normal. 30 of them stayed the same and were still obstructed. And then we had about 30 new ones that became obstructed during their deployment. So the only thing that really, that sorted out when we looked at this specifically, that dyspnea didn't seem to change, but we did see a difference in those that had self-reported increased wheezing during deployment. So that was the only marker that we could find suggesting that they had new onset disease. So we did see an overall improvement in spirometry and iOS values, and I know Eric is that we have not gone back and looked at individual changes per individual yet, and we're working on that right now. And these are the numbers that I showed you. So we had a fair degree of obstruction, but did not correlate whether they were obstructed pre-deployment, whether they had a history of asthma, smoking, or increased BMI, did not demonstrate a reduction in spirometry values post-deployment. So these were not predictive that the patients were going to do worse. And the only symptom that we found associated with worsening PFTs when they redeployed was a reported history of wheezing, which is not a typical question asked on our post-deployment health questionnaires. And I know we've talked about this in the past, and I think they're changing them. Anyway, I don't know why I put that in there. But anyway, that is STAMPEDE II, both our pre-deployment analysis and pre- and post-deployment analysis, and the other studies we're looking at spirometry. So.
Thank you again. Questions for Dr. Morris? David?
Yeah. So why don't you do paired analysis with the pre and post? You obviously have several hundred that are done that way rather than comparing group meetings.
Yes. Yeah. And after we had published this, it has been brought up by a number of people, and we're going back with our statistician right now to do a paired analysis to relook at that data from that standpoint, to see if there's individual variation that we missed doing the group analysis. But yes, that is something we are working on.
I guess I would just also underscore the importance of that question, particularly given the finding that 37% were supernormal. And just if you think about potentially having younger people that, because of physical activity or fitness, or analogously if you have a musician or people that are highly trained, in real world settings, those are the individuals where you can really miss progression of disease over time. And so just thinking about really the critical nature of looking at individual values.
Right.
And some of the data that you presented in the beginning as well, thinking about looking at changes in individual values versus percent predicted, because comparing within an individual, they serve then as their own control. So thinking about within individual comparisons of their actual
right.
rather than their.
But they really should. I mean, the predicted shouldn't change. I mean, these were mostly 6 to 9 month deployments, and so I don't think anybody gets shorter or gets older that much quickly while they're deployed. If it were over a longer period of time, yes, but it's one of the things that we do have to do is go back and look at individual values, and we can actually look at the actual value as well. And I mean, there are limitations simply because we did a singles. It's very hard to get this group of patients, and the only thing we're able to do is to get a single spirometry. It would have been much nicer to be able to reevaluate them on the way back who were abnormal and get more details, but it's very, very difficult to do. We had enough problems getting into the SRP site in the first place.
There's some problems with using BMI to reflect obesity or overweight, particularly in this population where people may be kind of bulky because they're working out. And I just wonder if you have thought about doing waist circumference or something that would maybe supplement your assessment that it's an obesity problem.
We could do that. That is routinely, well, it's not routinely done. For those people that don't meet the height weight standards for the military, they do measure abdominal circumference, but in the future we could look at that as well. But we did not do that with this study.
Question about the screening spirometry, the first study with the 9 participants. When you looked at the logistic regression and the predictors of abnormality, I think that was one of the instances where BMI came out to be the strongest predictor, but
Right.
some of the ones you would naturally think biologically should come out, for example, smoking should be associated
Right.
in a large enough population. Did you look at that as a continuous variable rather than just, because I think only about 5% were abnormal. So rather than a logistic regression of abnormal, normal.
No, I don't think we looked at it that way. I mean, the other issue is technically, because they're in advanced individual training, they have a history of smoking. They're not supposed to be smoking, so we really couldn't account, and we're not willing to ask the question of those individuals, are they still smoking? So.
Let me see if I interpret this correctly. What you're saying is that in the short term, they're before deployment and then post-deployment or testing 6 to 9 months later, I think you said. Is that correct? That you don't see really any significant change in lung function. So, go ahead.
Yeah, we don't see any significant change, but I mean, just like when we look at other groups, non-deployed, when we look at COPDers, when we look at asthmatics, I mean, unless there are very specific occupational hazards that we do require spirometry for, and even so, you need to do it over a longer period of time, that single pre- and post-deployment spirometry in and of itself, by itself, is not that helpful. If you're going to do it correctly, you should be having a more robust set of questions. You should be asking more respiratory symptoms. And we really should do it. Now, we did it at the SRP site. We really should do it where we have more capability for those people that are abnormal to further evaluate them, to do bronchodilator testing, to do bronchoprovocation testing, to do more, potentially do imaging. I didn't report it. We did get imaging on some of the individuals, pre and post. A lot of them didn't do it on the way back, and we didn't find anything on that. But just doing a single spirometry by itself is probably not all that helpful. And the issues with, now we had a respiratory therapist who was trained in PFTs to do it. If you just stick a spirometer in these SRP sites, I mean, one of the things all the pulmonologists know is that the test is only good as the person that does it, and there are a lot of issues with getting bad PFTs that don't meet ATS standards.
But in terms of using this kind of data to either support or deny the development of COPD, it really, this isn't how you go after it, I assume. I mean, that's a long-term kind of a study. So it says in the short term, you're not seeing much difference.
Right.
Whether there is risk, that would be detected by spirometry.
Much longer term, so to find specific individuals. Yeah, and I think the nice thing that from reading, for instance, the World Trade Center is that they had all the spirometry on all these individuals for a long period of time and were able to detect that difference. And we don't have any indication within the military itself. We have 800,000 people in in the Army alone, and we've deployed 3.5 million people, it would logistically difficult unless we were very selective in the population that we looked at. For instance, those that reported a history of asthma, I mean, clearly we should get PFTs on them before they deploy and look at them afterwards. But did they report that to anybody other than us? Maybe not. If they were feeling okay and weren't on any medications, should we? They may not tell us about that, which I think they should, and I think we should look at them very carefully before we deploy them. I've been amazed at the number of people who have been deployed with all sorts of respiratory illnesses that never should have been deployed in the first place.
Well, I'm afraid I have to disagree. I think it's too premature for you to make the statement that you don't see much change. There are two things. One, the analysis has to be done across individuals rather than across groups. Secondly, even your own data, with an average age of 31 and a standard deviation of 9 years, means a third or so or more of these men are in fact 21 or less. And we know the lung in the man grow to minimally probably 25. Now, and the other thing is women are different. Women are finished their growth by 18 or so. So you've got to separate out the men from the women. You've got to look at this well, if you look across individuals, I think you'll see. Now, you may be right, but I don't think the analysis to date would allow you to say that doing pulmonary function shouldn't be done because there are 8 million men,
Well, I have a paper to write, so.
Can you say how the demographics changed? Because you said you didn't get everybody in the post-deployment. Were the demographics basically the same, or did they change?
The demographics were pretty much the same. When we went back and looked at the group and compared them pre and post, the demographics did not change from the ones that we recaptured. I mean, you would think, because of the high number of Guard and Reserve, a lot of them may not have come back through there, but a lot of them did. So it didn't change in those two groups.
I just want to piggyback on what the gentleman was saying back there, that I just think it's a shame that the military will look at this, because if you just focus on it for such a short time, that it's a waste of money, that they'll look at it like, okay, well, we don't need to use a pulmonary factor pre and post deployment, that it's a waste of time and money because they're not seeing any change, when in fact I think it's a really good resource. It just wasn't done for a long enough period of time.
Thank you. I think we'll go ahead and move on. Thank you very much.
You're welcome.